Our next speaker will be delivered by Dr. Neilson Palabrica. He's a medical specialist 3 and ORMA, vice chairman at the Northern Mindanao Medical Center. He will be presenting the different surgical techniques in ASD. Dr. Palabrica.
Thank you. Good afternoon, everyone. Thank you so much, PSS, for giving me this 10-minute opportunity to talk. Thank you all of the previous speakers for making my talk today because much of what I'm going to say So again, good afternoon. Surgery of adult spinal deformity presents a challenging issue for spinal surgeons with high morbidity rates reported in the literature. The condition is progressive, relentless, complex spinal disease, often responsible for surgical measures that can improve treatment. ASD occurs as a result of a complex interplay of sets of different generations, leading to increased loads resulting in pain and deformity, coronal imbalance, causing spinal stenosis and distal disease, as well as muscle weakness. Patients experience psychological effects from poor prosthesis and, of course, mobility. In the presentation of Dr. Santo, the prevalence of ASD in the elderly population may be as high as 68%. And this number will continue to increase as people live longer and wanting to maintain their activity level high. Hence, a comprehensive and multidisciplinary management of this seemingly enigmatic condition needs to be improved and standardized. For the last 20 years, so much attention has been focused on the aging spine. The spine community painstakingly put up a committee with special interest to the aging spine population and came up with formula for classification and assessment tools. Several treatment algorithms were proposed and recommended, the best surgical procedures for specific clinical scenarios with common emphasis on the restoration of global spine balance and alignment. The mainstay in non-operative management of ASD is with NSAIDs and physical therapy. Selective cortisone injections are accepted forms of treatment, be it in the facet or selective nerve blocks, which is both diagnostic and therapeutic for the patient. Bracing slows progression of deformity and provides some comfort to patients. On the other hand, surgical deformity correction in ASD is indicated for progressive, disabling pain that has failed non-operative management or when progressive neurological deficits occurs. Multiple surgical interventions are currently available to manage each component of the deformity. Nowadays, large open procedures are seeing benefit by adding adjunctive, minimally invasive surgical solutions like XLIF, OLIF, and to some extent, endoscopic decompression techniques. However, the management of adult deformity remains controversial, with a lack of high-quality evidences to guide treatment, such as determining the best candidates for conservative versus surgical treatment, the best surgical procedures for specific clinical scenarios. Nevertheless, these patients tend to present with varying intensities of back or leg pains, and concerns about deformity progressions need to be addressed. Thus, an understanding of possible causes is important, as well as recognition of coexisting variables be given due considerations before appropriate recommendations for treatment, before treatment can be made. It was also presented in the previous speaker, by the previous speaker, that there are 3 types of ASD. Okay, so these are the idiopathic, or the residual, the de novo type, which is the most common, and the second most common is actually the secondary type of ASD. They differ in terms of curve patterns, vertebral segment involvement, the location of the curve, and of course, the curve magnitude. Furthermore, in 2012, based on the tight relationship between sagittal plane deterioration and quality of life, the Scoliosis Research Society proposed classification of adult spinal deformity by SWAB, incorporating the most clinically relevant parameters in the sagittal profile. And that would be the SVA, the PI and the minus the LL, and the pelvic tilt. In addition to the scoliotic deformity of the coronal plane with a Cobb angle more than 30 degrees. So a PI minus L value of less than 10 degrees, an SVA of less than 40 mm, and a PT of less than 20 are considered or are defined normal values in order to maintain good quality of life. Schwab et al. Further recommends that corrections in the sagittal plane should fall within the range of these given values. It is imperative to determine preoperative measurements or parameters in the planning of your surgery. Okay, so I will not anymore be discussing about this because I think this has been discussed many times. Okay. And so after optimization of the patient for surgery came planning. All right, so after all the evaluation of all those radiographs, taking all those measurements, then planning follows. Now, in general, the general indication for surgical curve correction with instrumental fusion were the following. Okay, so a curve more than 50 degrees, same as what has been previously mentioned. Intractable pain, curve progression, kysmesis, and of course, those with cardiopulmonary decline. A stable and balanced spine is the principal goal of deformity surgery in the elderly. And this often involves accepting less curvature correction. The smallest correction with the least complication, no, is the best, no? So relief of pain and obtaining a solid fusions are the other goals. Dr. Glassman's spine deformity study group suggests that restoration of the normal sagittal balance is the most critical goal for the reconstructive spine surgery, for any reconstructive spine surgery. However, adequate fixation of thoracolumbar spine with surgical implants can be problematic in the elderly patients for a number of reasons. Obviously, the poor quality of the bone and the stiffness of the spine remains a big concern. So, now this brings me to my assignment, which is the surgical techniques. Well, there appears to be a broad description of what was really assigned to me. But nevertheless, I'd like to go on with my presentation. There are two known techniques or approach used in ASD, and that would be the posterior only surgery, or with instrumental fusion, which is the most common. Indications of which are those thoracic curves more than 50 degrees. Most double structural curves, more than 50 degrees with relative flexibility. Selecting technique, selecting the technique or the type of approach needs to be discussed with your patients, because sometimes the patient would just simply want more straightforward, less complication, less possibility of complication type of approach. And most of this on a posterior only procedure. Another approach to ASD procedure is a combined anterior and posterior surgery with instrumented fusion. These are actually reserved to extremely rigid curves requiring anterior releases and circumferential fixation. As a rule, always extend when it comes to choosing the upper instrumented vertebra and the distal fusion level of the lower instrumented vertebra. As a rule, always extend the UIV to a neutral and horizontal vertebra, and that is the stable vertebra. And it should be above the main curve. If you have a fully lumbar segment affected, always extend the fixation not lower than T10, and that was the recommendation in the book, which is the neutral or horizontal vertebra. That is in terms of short fusion. Inclusion of sacral fixation in the presence of an L5-S1 pathology, it is recommended to purchase to the far cortex, where you have to have a bicortical cortex fixation of your screws pointing towards the sacral promontory, because that area is relatively cancellous, and if you don't get to the next cortex, your likelihood of having screw pull-out is relatively high. In selecting also the distal fusion level, you have to extend to the sacrum if any pathology of the L5-S1 is present, as in the case of an L5-S1 spondylolisthesis, spondylolysis, even as simple as a spondylolysis and facet arthrosis, or in cases of prior laminectomy. Sometimes we get so apprehensive whether or should we, or this doesn't look unstable, okay? We always think about instability around that area. But that's not the only parameter, that's not the only reason why you shouldn't cross or you shouldn't span that area of fracture, because eventually soon, especially in the cases of ASD or degenerative diseases of the spine, this would most likely degenerate. So if you consider also extending the fixation to the sacrum involving more than three levels of fixation, it was recommended that you have to include the sacroiliac joint. You have to fix because the sacroiliac joint, because if you just settle for a solo or an isolated fixation, the sacrum, the cantilever motion of the hip might affect and might cause pseudoarthrosis around that area. So it is recommended that you do sacroiliac fixations in cases of more than three levels of fusion, if you're entertaining 3 levels of fusion. And in cases also, now I'm sure that we've been doing this all the time, that whenever we have our fixation is insufficient, we always use the ever reliable bone cement. So the bone cement is indicated in patients with really frank osteoporosis in order to increase anchorage and make our fixation more stable. Now, this is the part where I will just be talking in a breeze. So osteotomies have been increasingly popular and have become part of the armamentarium of most adult deformity spine surgeons for effecting corrective change in the sagittal balance. They have become a vehicle of avoiding the time and morbidity of a separate anterior approaches in deformity corrections. So in this picture you see, what is this? This is an SPO, right? It's a Smith-Peterson osteotomy. So I will not go into the detail of this one. So you know what it is. This is Smith-Peterson osteotomy, and it can gain you about 10 degrees of correction. If you do more than 2 or 3 corrections, you can gain actually 20 to 30 degrees of correction, and I think that's it. All right? Though this one of the strongest corrector of the spine is actually with very high chance of union is actually a PSO. It is a very powerful tool for obtaining sagittal plane correction at single levels, and it can give you up to 35 or more degrees per level. However, since the procedure entails a wedge resection of the lamina, pedicles, and the vertebral body, blood loss can also be significant and sometimes may not be tolerated by aging patients. When anterior fusion are present, correction at the level of the vertebral body should not be at the disc. Okay? So in cases of post-infectious POTS disease, when there is an autofusion of 2 levels, no? So when you choose your line of resection, of wedge resection, it should not be at the level of the disc. It should be at the level of the vertebral body such that you can achieve fusion right away. So a 30-degree or more correction can be obtained through Smith-Peterson or pedicle subtraction osteotomies. In these cases, wherein you would be definitely manipulating the nerve, the exiting nerves, no? So it is actually recommended that we use a neuromonitor in order to avoid potential neurological risk. The use of fluoroscopy in patients with previous spine fusion surgery or decompression can aid in finding the pedicle landmarks, especially in the thoracic spine, and especially when doing osteotomies. This another type of osteotomy is what you call the VCR. This is what, in the case of Dr. Carnero, this is what he did. No? A VCR, this is a vertebral resection. It is a powerful tool that you really have to know. So you can really remove the entire segment. You can really remove the entire pathologic segment and use the removed segment as your bone graft and put it on a cage. So this is also a very powerful corrector of the spine. So anterior procedures are relatively less common in ASD, but in cases wherein there is augmentation of fusion that is in the L5S1, an anterior approach to the L5S1 in the form of an A-lift is actually a very good technique. And it can provide a very stable fixation around that area. So let me just share to you my guide. No, this is my guide in making my decision in the management of ASD. This is a guide. This is an operative treatment guide by Matsuyama. This is it has 4 or 5 levels. So let me just run this one through. When you have a lower leg pain, low back pain without any low back pain, instability, SVA of more than 50, kyphosis is smooth, kyphosis is sharp. All you need to do, the level of surgery that you have to do is just simply decompression. The decompression can even be made through limited decompression, similar to that of a tube decompression. You can do a simple tube decompression or even an endoscopic one. So I'll just leave you this one. No? So there are many proposed management in the treatment of ASD, but for all intents and purposes, the discussion I will have to discuss only one where I find it easy to understand. So this is the one that I find easy to understand, and it's relatively straightforward. But since I have been doing this for about for almost 2 years now, so far everything went well. So I'd like you to take a look at it too. So this is it again, just to give you a more focused picture. So with that, my talk is ended. Thank you.
Thank you, Dr. Palabrica. Our next faculty is Dr. Geraldine Rafaela Jose, and will be presenting